Good afternoon and welcome everyone to Preventing Healthcare-Associated Infection, Ventilator-Associated Events, VAE. This session is brought to you by Project Firstline Rhode Island under the Center for Acute Infectious Disease and Epidemiology at the Rhode Island Department of Health in partnership with the CDC. I'd like to thank you all for joining me today. My name is Lisa Ledoux. I'm an infection prevention training liaison with Project Firstline Rhode Island. And my Project Firstline team is behind the scenes in support of this webinar today. And here's our agenda for today's webinar. We are going to next go over learning objectives, learn what a healthcare-associated infection is, ventilator-associated pneumonia, VAP, versus ventilator-associated event, VAE. What is VAE and how do they occur? Infection control actions to prevent VAEs, knowledge checks, and then there'll be actually poll questions, and then we'll go into our key takeaways, and that'll be it. At the end of the refresher session, you will understand what an HAI is, learn the difference between VAP and VAE, define VAP and identify risk factors for developing a VAP in healthcare setting, know the signs and symptoms of VAP, and understand how VAP spreads in a healthcare setting, and then also review infection prevention practices to prevent VAP. So some types of healthcare-associated infections include catheter-associated urinary tract infections, known as CAUTI, central line-associated bloodstream infections, known as CLABSI, and as we are going over today, ventilator-associated event, VAE. And this is our third session in our HAI series, by the way. There's more to come. We have a lot on our site that we already have recorded. And also two other HAIs are C. diff infections and surgical site infections. And today, as I mentioned, we're going to be going over ventilator-associated events. So let's start with understanding what are HAIs, healthcare-associated infections. They are infections that patients get while they are receiving healthcare. No matter where you are, whether it be in a hospital, a long-term care facility, outpatient surgery center, dialysis center, or a primary care office, you are at risk for these infections. To develop an infection, germs must somehow enter your body. Healthcare procedures can expose you to germs that cause HAIs. And these germs can spread between patients, providers, staff, and visitors through unclean hands, unclean surfaces, or improper use of medical equipment, or reuse of equipment. Some of these germs are even resistant to medications, and they are a serious threat to healthcare safety. According to the CDC, 1 in 31 hospitalized patients will get an infection because of the care that they receive. And here are some terms that you will hear me use throughout today's webinar. The first is intubation, and that is a process where a healthcare provider inserts a tube through a person's mouth or nose into their trachea, also known as their windpipe. The next is ventilator. It's a device that supports the process of breathing by pumping air into the lungs of a patient who cannot breathe naturally. And then there's pneumonia, an infection that inflames the air sacs in one or both lungs, and it results in fluid buildup, fever, cough, and difficulty breathing. And there are a few types of pneumonia that we'll be going over next. But before we go over the types of pneumonia, I wanted you to see this image. This is an image of an endotracheal tube placement. And this view shows what it looks like to have a breathing tube inserted through the vocal cords and trachea and down into the lungs. There's a balloon at the end of this endotracheal tube that's inflated. And this is designed to prevent saliva, stomach content, or other body fluids from entering the lungs. So the specific type of pneumonia is classified according to how the patient acquires the disease. People in the community and people in the healthcare settings may be exposed to different types of bacteria and viruses. And here are the types of pneumonia that I would like to go over. There's community-acquired pneumonia, and that's a common lung infection that occurs outside of a healthcare setting. Healthcare-associated pneumonia. It's a type of lung infection that develops in patients who are receiving healthcare in a hospital, nursing home, or other healthcare setting. Aspiration pneumonia, which is a lung infection that occurs when a person inhales something other than air into their lungs, and it could be food, liquid, saliva, or even stomach content. And then there's also ventilator-associated pneumonia, VAP. It's when a patient acquires pneumonia while receiving ventilation on a mechanical ventilator. So the majority of today's webinar, we're going to be focusing on ventilator-associated pneumonia and reviewing infection prevention and control measures on preventing VAP. VAEs are among the most common hospital-acquired events in the ICU, leading to decreased patient outcomes and increased length of stay and possibly death. Hospitals want to reduce the incidence of these events, but to accomplish this, it's important to first understand how they are defined, how they're diagnosed, and what impact they have on the patient and hospital, and also what possible precautions can be taken. So why the change from VAP to VAE? In 2013, the CDC redefined surveillance for quality care in ventilated patients by shifting from ventilator-associated pneumonia definition to a ventilator-associated event definition. They looked at the following. They looked at subjectivity. Diagnosing VAP often relied on chest x-ray interpretations, which can be subjective and inconsistent between clinicians, leading to unreliable data collection. There is now a wider scope. VAE captures a wider range of complications beyond just pneumonia. Ventilator-associated pneumonia is an important complication of mechanical ventilation, but other adverse events also happen to patients on a mechanical ventilator. Also, by changing to VAE, it improves surveillance. By using more objective criteria, VAE allows for better standardized surveillance and data collection across different healthcare facilities. A ventilator-associated event is a complication or infection that occurs while a patient is using a mechanical ventilator. VAEs can be serious and even fatal. VAE encompasses various adverse events or complications such as adult respiratory distress syndrome, sepsis, pulmonary embolism, and pulmonary edema. These can occur in patients on mechanical ventilation, including VAP, which we will discuss a little bit later. VAE aims to capture a wider range of events beyond pneumonia and improve patient safety and outcomes by identifying and addressing potential issues related to mechanical ventilation. This is not just limited to infection that you would get if you were intubated. And because of this, not all VAEs are HAIs. In order for a VAE to be present, a patient must meet the following criteria. You need to be mechanically ventilated for at least 4 days. And the earliest date of event is day 3 on the ventilator. VAEs are also identified by using a combination of other objective criteria, such as deterioration in respiratory status after there was a period of stability or improvement on a ventilator. There needs to be evidence of infection or inflammation, and also lab evidence of respiratory infection. VAEs are designed to detect both infectious and non-infectious conditions. They also identify direct or indirect complications from mechanical ventilations. Infectious VAE is caused by a bacterial, viral, or fungal infection, such as a ventilator-associated pneumonia. A non-infectious VAE occurs from complications related to a mechanical ventilation. It occurs without an infection, such as atelectasis, which is a partial or full collapsed lung, or there could be pulmonary edema, which is buildup of fluid in the lungs, or as I mentioned earlier, acute respiratory distress syndrome. Basically, there is respiratory deterioration that is not caused by a pathogen. And here are some common causes and outcomes of VAEs. And some of the causes, as I've mentioned a few or earlier, it could be caused by aspiration of secretions from stomach content into the lungs, from ARDS or lung injury, atelectasis, pulmonary edema, barotrauma, which is lung injury from high pressure ventilation, pulmonary embolism, or sepsis. In the outcomes, you could have increased mortality. Patients experiencing a VAE have a significantly higher risk of death compared to those without a VAE. Also, VAEs cause extended hospital stay due to the need for additional treatment and management of complications related to VAE. Cause prolonged mechanical ventilation. VAEs often lead to a longer duration of time on a ventilator. And another outcome could be a tracheostomy, which is a surgical procedure that creates an opening in the trachea and inserts a tube to allow air to enter the lungs. And that's usually done when there is prolonged mechanical ventilation. And also, there could be multi-organ failure. VAEs are identified by using a combination of objective criteria. To identify a ventilator-associated event, healthcare professionals look for how long has this patient been on the ventilator? Has there been a period of stability on the ventilator followed by a clear deterioration in respiratory status? Are there signs of infection or inflammation, such as elevated white blood cell count or fever or hypothermia? What is the clinical presentation? How are the vital signs? Have the secretions increased or changed in color? They're going to need to look at laboratory tests. And has there been a change in chest x-ray or a chest CT scan? With the key criteria being a worsening oxygenation status after a period of stable or improving respiratory function on the ventilator. And then there's clinical judgment. Diagnosis of ventilator-associated pneumonia can be difficult. It requires a combination of clinical, radiographic, and microbiologic data. Is there something else going on with this patient? Could it be pulmonary edema or aspiration pneumonia or pulmonary embolism? While objective criteria are used, clinical judgment is crucial in interpreting the findings and considering other potential causes of a patient's worsening respiratory status. We're going to next discuss ventilator-associated pneumonia. We're going to define it, review what causes it, and how, most importantly, how we can prevent them. Ventilator-associated pneumonia is a lung infection that occurs in patients who are on a mechanical ventilator for more than 48 hours. It's a common hospital-acquired infection that can lead to longer hospital stays and higher medical costs. It refers specifically to a lung infection that develops in a patient on mechanical ventilation. VAP occurs when in the presence of a breathing tube, which is inserted, as I mentioned earlier, down into the airway to help assist in breathing. And it's caused by microorganisms, including bacteria, viruses, and fungi that enter the lungs through the ventilator circuit or their aspiration of secretions. And here are some common organisms that can cause a VAP. Staphylococcus aureus, including MRSA, Pseudomonas aeruginosa, Klebsiella, Enterobacter species, and Acinetobacter species. Okay, so next, let's look at the 5 elements of how germs spread and how they can cause a VAE. First, you have to have a reservoir, which is the source of the germ. This is a place where the germ lives and multiplies. This could be in the respiratory system, which could be part of, in the nose, in the throat, and the mouth. Those could be the reservoirs. Next, you have to have a susceptible person, and this is somebody who can be infected. This is someone who could be on a mechanical ventilator and could potentially become infected. There needs to be the ability to bypass the body's defenses, and this refers to the body's natural mechanisms that fight off infection. The endotracheal tube provides the germs direct access to the patient's lungs. Germs need to survive, the ability of the germ to stay alive. Germs live in water, and ventilators have water. Ventilator circuits are humidified and might have water buildup in them. An aspiration of non-sterile water or other solutions during care can introduce harmful germs into the breathing tube. And then you also need the pathway, and this is how that germ travels. This is the method by which the germs move from the reservoir to a susceptible person, and such could be through direct contact, airborne transmission, or contaminated food, or a healthcare task such as intubating a patient. It is important to know that removing any one of these elements helps to prevent the occurrence of an HAI. So here's the image of how germs can potentially travel and cause VAP. Healthy individuals normally have various defense mechanisms to prevent the development of pneumonia. These include cough reflex, mucus clearance, and also the anatomy of the airways. VAP occurs when bacteria or viruses are introduced into the normally sterile lower respiratory tract and overwhelm the host defense mechanisms. A VAE infection typically occurs through the aspiration of bacteria from the oral pharynx, which is the middle section of the throat. And this pathway is often considered the primary route for VAP infection. And here are some key points about VAP pathways. Colonization of the oral pharynx. The bacteria naturally present in the mouth can multiply significantly in a ventilated patient due to reduced oral hygiene or altered swallowing abilities, leading to heavy colonization of the throat, which can be aspirated into the lungs. And then there's aspiration, where small amounts of contaminated secretions from the oral pharynx can be aspirated into the lungs during normal breathing or during ventilator manipulations, especially when a patient is not fully awake or has impaired cough reflex. There could be contaminated equipment. Improper cleaning and disinfection of ventilator tubing, suction catheters, or other respiratory equipment can introduce bacteria directly into the airways. And then also another pathway is healthcare worker transmission. Healthcare workers inadvertently transfer bacteria from contaminated hands or surfaces to the patient's airway during respiratory care procedures. So some patients may present with the following symptoms. There could be changes in breathing, difficulty breathing, demanding the need for higher level of ventilator support or increased respiration rate, which is referred to as tachypnea. Increased heart rate. They could have fever, decreased oxygenation, where there's a drop in oxygen levels, which can be detected by a pulse oximeter or arterial blood gas lab draw. Also, elevated white blood cell count. There could be an increased number of white blood cells, indicating an immune response to infection. There could be new or worsening chest scans showing either new or progressive infiltrates or consolidation on your chest X-ray or CT scans. It could be a change in secretions. There could be increased secretions, or there could be purulent secretions, which means the presence of pus in the respiratory secretions. Pus is a thick yellowish fluid that is produced by an infection. And to note, these symptoms often prompt further testing to confirm the diagnosis and determine the causative organism, guiding for appropriate treatment. Risk factors that can impair lung function and increase the risk of infection for patients on a mechanical ventilator include some of the following. Healthcare personnel not properly performing hand hygiene. There could be excessive sedation, poor oral hygiene, which can lead to the growth of bacteria in the mouth, which can be aspirated into the lungs. Inappropriate body positioning. By keeping the head of the bed too low, that can lead to poor drainage of respiratory secretions and increasing the risk of infection. Contamination of the ventilator circuit, either from improper handling or lack of regular changes, and that can introduce bacteria directly into the patient's airway and lungs. Improper ventilator settings. If settings are set too high, that can cause lung injury. Excessive fluid administration can lead to pulmonary edema, which can alter your respiratory gas exchange. And also inadequate weaning. Prolonged use of mechanical ventilation without attempts at weaning can increase the duration and exposure to potential pathogens, thereby increasing the risk of infection. So we know prevention is better than treatment. And the management of VAE requires a multidisciplinary approach involving physicians, nurses, respiratory therapists, and infectious disease specialists to tailor the treatment to the individual patient's needs. The concept of care bundles was introduced by the Institute of Healthcare Improvement, and care bundle is a set of evidence-based practices that, when implemented together, lead to better patient outcomes than if implemented individually. They contribute to infection prevention by reducing unnecessary antibiotic prescribing, leading to decreased incidence of antibiotic resistance in healthcare facilities. We'll be going over those in the next slide. So here are some of the care bundle actions that will help prevent a ventilator-associated event. Avoiding mechanical ventilation and preventing reintubation, use of appropriate sedation, preventing aspiration risk, hand hygiene, oral hygiene, maintaining a closed suction system, and daily weaning protocols, and also providing early exercise and mobilization. So first, avoiding intubation and prevent reintubation. With advances in medical care, we now have several widely available options to support a patient's respiratory status besides intubation. Mechanical intubation can be avoided through non-invasive ventilation or other strategies. While in some cases intubation is the best decision, many healthcare facilities have access to high-flow nasal cannula and CPAP or BiPAP for respiratory support, and may enable a segment of our patients to entirely avoid intubation. Minimizing sedation. Potential strategies to minimize sedation include protocols for targeted light sedation and daily sedative interruptions. Some people call it sedation vacation for patients without contraindications. Conscious sedation can lead to an accumulation of sedatives and cause oversedation. And oversedation is associated with increased duration on the mechanical ventilator. So to prevent the risk of aspiration, first, proper positioning is important. Keeping the head of the bed elevated reduces gastric reflux and subsequent risk of aspiration. Keeping the head of the bed elevated between 30 and 45 degrees helps prevent the aspiration of those secretions into the lungs and lowering the risk of VAP. Avoid the supine position, which is lying completely flat. Avoid unplanned extubation. That could happen either accidentally by healthcare personnel performing tasks bedside, or when the patient pulls on that tube due to undersedation and increased consciousness. As stated in the previous slide, sedation needs to be monitored carefully for under-sedation and for over-sedating. Secretions are potentially able to bypass that ET tube cuff, especially when it is deflated. So secretions that pool above that tube but below the vocal cords are a potential source of pathogens that can cause a VAP. And also ensuring that the correct cuff pressure is maintained. You want to ensure that it's inflated enough to avoid aspiration, but not overinflated to cause tracheal damage. Maintain endotracheal tube cuff pressure between 20 to 30 centimeters of water. And this narrow range ensures that the cuff pressure is, again, high enough to seal the airway, but low enough to maintain tracheal capillary perfusion pressure. So it's important that that cuff pressure is checked and adjusted frequently. Providing early exercise and mobilization is important. It's considered a key strategy to prevent VAP by promoting lung function, reducing the risk of aspiration, and improving overall physical condition, making it a crucial part of patient care for individuals on a mechanical ventilator. Research supports that its effectiveness in lowering VAP rates and potentially shortening the duration of mechanical ventilation in ICU stays. Early mobilization helps to prevent atelectasis by improving lung expansion and mobilization of secretions, which can otherwise lead to bacterial growth and pneumonia. Mobilization should be done progressively, starting with simple movements, like sitting at the bedside and then gradually progressing to standing and walking, depending on the patient's tolerance. Collaboration with healthcare team, physical therapists play a crucial role in designing and implementing safe and effective mobilization programs tailored to meet the individual's needs. Hand hygiene. Clean hands are safe hands. Rigorous hand washing and sanitizing practices by healthcare personnel reduce the transmission of pathogens. Our hands carry so many germs that we cannot always see. Hand washing or use of alcohol-based sanitizer upon entering the patient's room and also upon exiting the patient's room. Washing hands before and after touching a patient. Before and after an invasive procedure. After body fluid exposure. Also after touching patient surroundings. And then also after glove removal. Oral health quickly deteriorates in mechanically ventilated patients. Some patients sustain injuries to the oral mucosa during the intubation procedure, and after intubation, patients are prone to dry mouth, which allows for bacteria growth in the oral cavity. These factors, in addition to a severely compromised immune system, can cause an increase in bacterial colonization in the oral mucosa, with endotracheal tubes serving as that direct route to the lungs. So adequate oral care can reduce bacterial overgrowth and reduce the risk of infection. Performing frequent and thorough oral hygiene reduces the colonization of all this harmful bacteria that can be aspirated. And also, oral care, including toothbrushing frequently, is essential. The closed suctioning systems are important. By maintaining a closed suction system for ventilated patients, it ensures that the suction catheter is inserted into the patient's airway through the ventilator circuit without disconnecting the patient from the ventilator, and also allowing for the removal of secretions while maintaining continuous positive airway pressure and minimizing the risk of a drop in oxygen levels, and also preventing infection by preventing environmental contaminants from entering into the airway. Daily weaning trials. Ventilator weaning protocols can be ineffective in shortening the mechanical ventilation duration. Nurse-led or respiratory therapist-led ventilator weaning protocols include daily interruption of sedation and coordination with a spontaneous breathing trial. They've been effective in removing patients from the mechanical ventilation quickly and appropriately. It is well known that the sooner the patients are extubated, the lower their risk of developing VAP. One of the most effective ways to make sure that patients are extubated as soon as possible is to perform daily spontaneous breathing trials and extubation readiness assessments. Assess the readiness to extubate daily in patients without contraindications. And deep vein thrombosis, DVT prophylaxis. Ventilated patients are at high risk of developing DVTs. So pharmacological prophylaxis is used by administering a blood thinner. And mechanical prophylaxis, such as sequential compression stockings, may also be used along with pharmacological prophylaxis. Some patients may receive both pharmacological and mechanical prophylaxis, while others may get one or the other, depending on the clinical situation. So what can the facility, what's the facility's role in preventing VAEs? Well, the facilities can ensure policies that make sure that the policies reflect current evidence-based practices, going by CDC guidelines and recommendations. It's important to ensure that staff competency is maintained. Checking to make sure that staff caring for patients on mechanical ventilation is that you check that upon hire annually. You could do it at new hire orientations. You could have annual skills fairs, have the staff return demonstration to evaluate their competencies. Conduct routine audits on ventilator care practices. And it's important to provide feedback to frontline staff and leaders. Establish the adherence and monitoring program for measuring the prevention care practices. Provide tools and audits for measuring the adherence. And again, giving back the results to the staff really allows for a lot of buy-in when they know all the data that you've collected. And here's a good slide to show reported data on HAIs. This is the CDC has released the 2023 National and State Healthcare Associated Infection Progress Report, which shows progress in preventing several important HAIs in acute care hospitals compared to 2022. This HAI progress report continues to show decreases in HAIs that align more closely with progress made prior to the start of the COVID-19 pandemic in 2020. So you can see where the green downward arrow signifies a decrease in the number of infections, and the red upward arrow signifies an increase in infections, and NA indicates that that specific HAI surveillance was not performed in that facility. So you could see there's a 5% decrease in VAEs in acute care hospitals. There was no change in LTACs, but you can see the decrease there. So this progress report is great, and the link to this site will be provided at the end with the resources. Okay, so next we are going to go over some poll questions to check and see your knowledge on VAEs. Okay, we have our first question here. What does VAE stand for? Is it A, ventilator acquired episode, B, ventilator and event, C, ventilator associated event, or D, none of the above? Very good. The answer is C, ventilator associated event. Good job. We'll move on to the next question. How can you prevent VAE? A, wash your hands. B, elevate the head of the bed 30 degrees. Maintain a closed or sterile suctioning circuit. D, provide frequent oral care. Or E, all of the above. Excellent. Yes, the answer is E, all of the above. Yes, we know that all those actions help to prevent a ventilator-associated event. Okay, next. Which component is not included in the care bundle for prevention of VAP? A, oral care. B, head of the bed elevation. C, daily sedation vacation. Or D, administration of antibiotics. What is not included in the care bundle? Excellent. The answer is D, administration of antibiotics. We know oral care, positioning of the head of bed, and daily sedation vacation are part of the VAE care bundle. Antibiotic administration is not included in the prevention. Okay, and here's our next one. Are all ventilator-associated events considered a healthcare-associated infection? Yes or no? The answer, no. We reviewed today that not all VAEs are HAIs. Good job. And our last poll question. How should the head of the bed be positioned for a patient on a mechanical ventilation? A, 0 to 15 degrees, B, 30 to 45 degrees, C, lying flat, D, position doesn't matter. And the answer is B, 30 to 45 degrees, because we know that keeping the head of the bed at 30 to 45 degrees helps to prevent pooling of secretions that can go into the patient's lungs. Okay, and here are our key takeaways for today's webinar. VAEs are common hospital-acquired infections. However, not all VAEs are HAIs. VAE and VAP are both terms related to complications that can occur in patients receiving mechanical ventilation in healthcare settings. VAE is a broader surveillance framework that encompasses various complications associated with mechanical ventilation, including VAP. VAP specifically refers to pneumonia that develops in mechanically vented patients. And VAE, including VAP, can be prevented by implementing and adhering to the care bundle. And here are our Project Firstline resources. You can also email Project Firstline directly if you have any questions. And go and click on our live events link through our website. And you can also follow Project Firstline on social media. You can follow us on YouTube, Twitter, Facebook, Instagram, and LinkedIn. And here are the references that were used for today's webinar. And I thank you again for joining me today. Please email rido.projectfirstline@health.ri.gov for any questions. Thank you so much. Take care.